Hi, everyone. Good morning. My name is Courtney. I am the brand ambassador for the Visiting Nurse Association of Ohio. I am honored to introduce to you today our speaker and presenter, Angela Golic. She is a rehab field support manager for the VNAO of Ohio. She is a physical therapist as well as a therapy support resource for clinical nursing managers. She provides clinical support for 2 teams and is part of the education team and onboarding team of new therapy staff. She received the Samuel G. Lucarelli Legacy Award in 2017 and most recently, Therapist of the Year for 2020. She has 20 years of experience at the Visiting Nurse Association and 30 years as a physical therapist and serves as an advocate for the rehab staff as well as her patients. She is looking forward to assisting in the marketing department, as well as fundraising for the VNA and recruiting new business ventures. Prior to her service at the VNA, she worked at Lake Hospital Systems, University Hospital Home Care, and Layton Physical Therapy, and early in her career, she worked at St. Vincent Charity Hospital. Angela lives in Mentor with her husband of 29 years and has 3 grown children. She loves to travel wherever there is snorkeling or a dive site to explore and the sun is warm. Angela, we're so happy to have you here today, and we're excited to hear everything that you've got to say about your career and therapy. As I set up the slides, I would like everyone to know that I had the opportunity to meet you in person and talk with you, and your passion is so refreshing, and I'm excited for everyone to learn about you and what you do.
Thanks. Thank you so much. And like Courtney has mentioned, I have been with the VNA. It will be 20 years in October. I remember I got my call, I put in a resume, and I got a little postcard in the mail saying they weren't interested. And then about a year later, I got a phone call asking if I would consider interviewing, and it's been history from there. I have been pretty much in every job position you can hold as a therapist at the agency. I started off PRN because I had 3 small children. And what I really loved about being a physical therapist at the VNA was that it was flexible, and I was able to really pursue my career and advance myself, as well as completely provide for my family. And home care has been what it's been for me, a blessing. And I am now currently an empty nester. My youngest just is in his 2nd year, just finished his 2nd year in college. So last year, I jumped in with both feet, I should say in 2019, and became a rehab manager, and most recently became a hybrid role as a manager for assistant for all the 4 clinical managers that we have for all of our branches. I live in Mentor, but I was originally a West Sider, so I'm very familiar with all parts of the state that we serve. And I was asked to present about what therapy does in home health and why it's so important. You can go to the first slide. So there are 3 branches of therapy: physical therapy, occupational therapy, and speech language pathology. We all interconnect. We're able to work together for a big holistic approach to patient care. Physical therapists tend to be more physical with balance and gait, transferring, can the patient move in their home. Occupational therapists tend to be more towards a functional ADLs. Can they bathe themselves? Can they cook for themselves? Can they feed themselves? And speech language pathologists work on their speech, their ability to communicate with other people, and cognitive therapy as well. But we all kind of work with the same things together as a team. Okay, next slide. As well as being our typical therapists, when we graduate, we all have a bachelor's and then a master's, and now even in physical therapy, you have to have a doctorate to be a physical therapist. They tend to teach you generalizations in college, but then when you branch off, you realize that you have passions, and we all have passions as therapists, and there are certifications that you can get depending on the discipline that you are. In home care, we typically see geriatric being our number one focus, but we're also vestibularly trained for balance, and there's actually certifications you can get to really focus on vestibular therapy and to figure out why patients are falling. And we do highly focus on orthopedic as well and cardiovascular, but there's other specialties as well. Hospice is a big focus for us. I'm personally trained in hospice. We have certifications for dealing with special needs of patients, including more diverse equipment and how to progress a patient as they progress through the stages of their illness. We're also behavioral and mental health experts, and physical therapists are now up and coming wound management specialists. They're training physical therapists in sharp wound debridement, which is something that even RNs don't do and are not trained on. We have a therapist that came in to help us from New Jersey, helping us with our training of our boot camp assistants. And he is very highly specialized in wound care, and it's not my calling, but I find it to be very interesting that we can branch off as clinicians into so many different branches. Typically, physical therapists, they go to school and they say, I'm going to work in sports. That's like 99% of a physical therapist mindset when they go into the field. And then they find out that sports is not everything. There's so much more that we can offer, even in neurology, with prosthetics and orthotics, and even in pediatrics. I had a short stint in pediatrics when I first became a therapist, and I worked in a school, and that was very short-lived. It was not my calling, and I found that my calling was definitely in geriatrics. But we even work in outpatient facilities with doctors, with teams, and we have a high training in electrophysiological sciences. So these are just some of the specializations and talents that physical therapists have. Okay, next slide. I'm not going to pretend to be an occupational therapist, but I work with some of the best. They're very highly trained in wheelchair assessments for clients. A lot of times patients will come home and they really need special seating, wheelchair modifications, and that's when you consider bringing an occupational therapist in on the case. They can take a look at the patient and the way that they slide and move, and see how we can best help these patients in their wheelchair positioning. Occupational therapists are very good with brain injury and autism and diseases and injuries of the mind. But they also work highly with getting a patient back into community mobility. Can they drive? We actually have occupational therapy departments in an outpatient setting where we can actually take somebody and put them behind a simulator and get them back behind the wheel again, or at least assess if it's possible for them to drive again. They go hand in hand with environmental modifications. So if their home is being built, they work with the physical therapist, and we help make sure that their doors are wide enough and they have the position and the ability to function in their homes. They're also highly trained in upper extremity. So whenever we have a client, and there's both physical and occupational therapy involved in the case, we tend to break off upper extremity to OTs and lower extremities to physical therapists, just so that we're not overlapping in what we're doing. But we're all working towards the common goal to get these patients up on their feet and moving. They also are highly involved in pediatrics as well, and 9 out of 10 times you'll see an occupational therapist that is hired in the school setting. But in home care, it's all about that patient's ability to shower, to feed themselves, and what can they do and what can we do to make them more independent. Okay, next slide. We had a wonderful speech therapist presenting when I did this presentation for our team meetings, and I'm going to do the best I can to represent speech therapists. And when I started researching all the different things that you could be specialized and licensed with speech therapy, it was mind-blowing. In home care, we are asked frequently by our physicians if our therapists are trained in the Lee Silverman voice treatment. This is for Parkinson's patients. And I don't know if a lot of you have access or experience with Parkinson's patients. They tend to have very low voice volume. And some of that is due to the fact that they just don't have diaphragm strength, and they just don't have the ability to put together full sentences. So this certification with speech therapy really focuses on Parkinson's patients. But we also get asked about our vital stim. I had personal experience. My mom had tongue cancer, and with radiation and all of the chemotherapy, they really damaged her ability to swallow. And I sought out a speech therapist because I thought possibly this vital stim would be able to help her. And although it was not successful for her, I have seen so many people's lives changed by vital stim, where they actually put electrodes on certain muscles and on the throat while a patient's eating, and they retrain these patients how to swallow. Of course, that is life-changing for a lot of people. Most of our speech therapists focus highly on fluency and swallowing disorders, but they're very involved in cognitive therapy as well, and they work hand in hand with occupational therapists in trying to get these patients some kind of a routine on how to remember things, how to make their days more structured. Okay, next slide, please. So when would someone refer a physical therapist? We use the OASIS in our guideline, and there's several assessments that we do in the OASIS where we actually have the patient physically attempt to do certain things. Is this patient showing weakness? Do they have a balance deficit? When they go to stand, do you notice that their balance is off? Do they have difficulty showering? Every home is different, and physical therapists will look at that home and help the patient with these problems. We also consider therapy after recent surgeries, because just because they were able to function in one way before the surgery does not necessarily mean they'll get back to that level, but we certainly try and hope that we can help that patient return to their pre-surgical state. Next slide. When to refer to an OT, you can watch a patient also during the OASIS. Are they able to even dress themselves? Can the patient lean forward? One of the biggest things I ask a patient to do is just lean down and tie their shoes. If they can't reach their feet, they're probably not able to dress themselves fully. They're not able to clean themselves well. And so you refer an occupational therapist when you have these problems with these motions and with these skills in home. Can they feed themselves? We have a lot of bedbound patients. Are they able to feed themselves? Are they able to roll in bed? And we also help with equipment modifications, and we help the nurses determine what level of pressure mattresses that these patients need, depending on the level of decubitus ulcers they may have or their risk for developing pressure ulcers. And they also, like I said before, they really do work with cognitive. So if you have a patient that just can't put the words together and they can't figure out the sequencing of their sentences, or they forget what time they ate or what time they're supposed to eat, refer an OT. But the number one reason to get an occupational therapist involved would be when you're ordering a home health aid. So if this patient does need help bathing, get an OT involved. They can help with the actual bathing process, not just the transfer in and out of the shower, but what happens once they get in. Okay, next slide. And again, when do you refer to a speech therapist? You look at cognitive issues, when patients have significant forgetfulness, if they're having problems putting their sentences together, any kind of communication problems from hearing and maybe speaking back, or even following 1 or 2 step commands. If you ask somebody, hey, can you open your eyes, or can you open your eyes and then blink twice? That would be an example of a 2-step command. If they're having problems following two-step commands, you can get a speech therapist involved, and it will help them process communication in general. And any nutritional concerns. I've had patients that were just clearing their throat a lot when I was working with them. That would be a number one sign that they potentially could be aspirating on just their saliva. And it would be a really good idea to bring a speech therapist in just to assess their ability to sit up straight and swallow food and prevent them from developing aspiration pneumonia. Okay, next slide. So what do we do when we walk into a patient's home? We keep in mind that every patient's home is different. We take a general history. We ask them what they were able to do prior to their current situation. We ask them their goals. We do a general strength assessment, and we look at their balance and their transfers, but we really focus highly on pain. Most patients will not feel like we've done anything for them if we cannot help them in any way with their pain. So that's one of our big focuses on our goal setting, is to make sure that we address their pain and each and every visit. We'll take a look at their wounds. We'll look at their lower extremity swelling. We did have a lymphedema program for a while at the Visiting Nurse Association, and we still have clinicians that are certified in lymphedema, and we're able to make recommendations to help our patients with edema reduction. We also look at their walking status and basically how their homes are set up. How many stairs do they have just to get into their house? How many steps do they have to enter to access their bathroom or their bedroom? How can we temporarily set up their home in conjunction with OT to look at their houses and to determine how we can make their house more functional? I remember when I first was looking for a house after baby number 2 with my husband, and he asked me what I was looking for in a home, and I said, I need a house that has a bedroom on the first floor. And he wanted to know why I was thinking about that. And I said, you know, at any point in your life, you could have an injury, even if it's a knee scope or an ankle problem or just a temporary injury that sets you back. And if your bedroom and bathroom are on the second floor of your home and you cannot do steps, that's a huge imposition for you. So we look at patients' homes and we try to figure out how to modify that house, how to modify that patient's treatment to help them in their home and get them to that ability to do stairs. We also look at their safety. I mean, do they need a railing? How can we make their home a little safer? We look at if they have throw rugs, if they have tiles loose. Can we recommend maybe a different type of railing system in their shower? Do they have an extended hose to help them so that they're not getting plastered by water as soon as they enter their shower? Can they control the situation? And then we look into deeper into their actual home safety. Is their caregiver really available and willing to help them? How can we involve social workers in hooking them up with community resources where they can be helped by their community with meals, with maybe some reduced cost housekeeping, maybe some private duty home health aid that would help them in their home. And even more so, if they have a pet or rodent problem, that we can help them get them the resources they need to make their homes physically more safe for them. Okay, next slide. So we do objective testing with therapy. Each discipline has their own set of tests. And the reason why we use tests is to make their goals more measurable. To be honest with you, if we cannot show progress to an insurance company, that's going to really impact our reimbursement. But more importantly, if we can't show patients that we're making a difference, they're not going to cooperate with their home exercise program. They're not going to do what we ask them to do. So we do set 30-day reassessments, and we use these objective tests to show them, hey, Mrs. Smith, when we first started with you, it took you 65 seconds for you to stand up from your chair, walk 10 feet, turn around, come back, and sit back down. And today you're at 42 seconds. And you explain to them that maybe that small improvement in time can actually save their life, like in a house fire, or their ability to get out of that home quickly in case of an emergency. Now they can stand up safely and get out of their house in maybe 20 seconds where it took them 30 before. Or just in general, the 30-second sit to stand test. I'll do that with a patient where I'll actually time how many times they can stand up and sit down in 30 seconds. That will tell me a lot about their balance, about their strength, about their self-confidence, and about their safety just to get on and off the different surfaces in their home. Occupational therapists will use several, and they have hundreds actually, tests for cognitive impairment, and we can actually show patients that we're improving their memory and their cognition. Most of these tests are very easy to run through. Our speech therapists run through a Cognostat and other swallowing and measurable tests, and it helps us build our goals. It helps us work with our patients in adjusting our maybe our treatment and our plan of care if we're not meeting our goals. But objective testing is where it's at and where it's going to be for some time now. Okay, next slide. So when we set our goals and we set our treatment plan, of course, like I had just mentioned, we're going to make our goals measurable, and we're going to make them objective, and we're going to make them patient-driven. We do set some short-term goals for patients to show them how they're progressing, and long-term goals, and we individualize them. We're very limited now with insurance companies. It's so hard being a clinician in the field, knowing that you have a patient with a certain insurance that will probably only give you 4 visits. And we have to be very creative on how best we're going to utilize those 4 visits to get that patient the most bang for their buck. Some insurance companies are really good at letting us continue as long as we show that we're meeting our goals and that these patients are progressing. But we do have insurance plans that are very limiting, and we have to be very, very, very focused in our care. We do use a team approach, especially in those circumstances, so that we can tag team this patient and make sure that they're covered from head to toe by the time that we have finished our treatment plan. And we highly involve caregiver participation. We educate them so that they know what to do and how to take over once we leave that patient's home. We may not have met all of our goals, but if we've given them the tools over time to be successful, these patients will be benefited in that way, and they'll continue to improve over time. And then we reassess, and if we're not able to do more for this patient, then we send them and consider sending them to outpatient. I like really sending a lot of my total joints and my back injury patients to aquatic therapy. I really think it's a great thing for them. Sometimes they don't have access to this, or they have a fear of going in water, but we work with doctors and we figure out what's the best scenario for these patients to carry on after we're done with them in the home care setting. And we help set up all of that for them. Okay, next slide. How to refer to physical therapy. Our nurses really know well that at the start of care, if therapy is not ordered, they call the doctor, they get an order, they'll plot a visit on our calendar, and they'll make a general evaluation and treat and give us kind of an idea of what they're looking for. Like they'll let us know, hey, this patient's having a problem with balance, or they're frequently falling. And then they email our Ohio Rehab Support, in which our schedulers are attached. And then they include the clinical manager of the branch so that that manager is on top of things and making sure that that patient gets timeliness of care. We don't try and promise our patients any specific start date, but we try to get out there within our 5-day window, because if we can get out there, we can help that nurse make adjustments to her OASIS, get a better clinical score on our patients, and really, truly get a good picture of what this patient is presenting with from the start. Okay, next slide. Katie Millard would have done a cognitive presentation at this time. I don't think she is on this phone call. And I would like to actually have you guys consider doing a speech therapist separate presentation at a later time, because she's really interesting, and some of the things that she can teach can even help us as we start going through the aging process. I found her tips to be helpful, just to help me keep my day sometimes from start to finish going in an even flow. And I'd like to open it up now, I believe, for questions for any of you, if you have any. And I don't know if anybody is on on a mute. If you *6 yourself, you'll be able to join in.
How long does a therapy session generally last? You said some insurance companies only allow 4 visits.
Correct.
Can you extend that? Or can you do a half a visit, half? I mean, how do you make sure that they're completely taken care of after those
Sure.
4?
So I am an old school therapist back in the day, and you have, with productivity expectations and with the level of skill that you are, if we have an assistant out with a patient, they're typically running 45 minutes a visit. And that is a really good length of time to get a grasp of the patient and to work with the patient, and not only instruct them in some of the things that you're going to see in their folder, but also get deep down into their visit. As a physical therapist, when I go out and I'm doing a start of care, because we do have all 3 of our disciplines are highly trained in doing starts of care, my start of care typically is at its minimum 2 hours, unless the patient's kicking me out of the door, because we're doing a lot of things as a clinician. Not only are we doing medication entries that RNs would do, we're focusing on the therapy aspects as well. And I make sure that when I leave a patient's home, even on a start of care, they at least have a small home exercise program to get started with. If we're going in for an evaluation, I typically run an hour and a half with that patient, going over all of the assessment things that I discussed above, and involving them in goal setting. And that's where I sit down with them and I say, okay, what's your goal? And it's surprising that my goals are not necessarily what their goals are. They may have a niece's wedding that they want to get to, and that's all they want to be able to do is leave the house. They come up and in that assessment. So, and typically a follow-up visit for me, I'm somebody that stays in a patient's home for a good hour. I'm giving them as much attention as they can handle, and I'm also giving them as much education as I can in each visit. But I'm also giving them my phone number. My big joke with them is I'm not a lawyer. I don't charge by the hour. If you have any questions, please pick up the phone and call me. I'm more than happy to help you out with any questions you have after the fact or any clarifications. Hopefully that answered your question.
Yes, thank you. I was also wondering, with equipment needs, do you bring things with you that the person can use?
So I have I have an arsenal, I like to call it, of equipment that I keep cleaned and regular in my arsenal garage, I call it. I have a shed that's just physical therapy stuff. We used to be able to send patients to Lake County Council on Aging, but with COVID, they don't want the responsibility of loaning out or giving out equipment that they haven't cleaned. So if I feel that a patient might need one walker versus another, I may bring in a sample piece of equipment before I have them buy something, because I certainly don't want them wasting their time or their money getting a piece of equipment that's not going to be used and not returnable. It's very likely that they come home with a lot of the stuff that they need from the hospital or rehab setting. But if they don't have what they need, we help with helping with the DME number on the back of their insurance card, because every insurance has a different DME company they want them to use. And we expedite and help these patients get the equipment that they need. Anything from a simple cane to the most state-of-the-art bathing equipment, chairs that actually take you down into the bottom of the tub. So we help the patients figure out what equipment suits them, and then we help them get it. We get the right doctor's orders, and in a lot of times we write the letters of medical necessity. I know with wheelchairs in particular, that's a good 3-hour assessment in itself, because we meet with a wheelchair provider company, and together we fill out the seating and the type of mobility that the wheelchairs are going to be. So we're highly involved in equipment management and maintenance.
I'm just so impressed by everything that you offer your patients.
Oh, thanks.
All the way from equipment to getting into the pool. It's great. Thank you for all your hard work. It's nice.
Angela, I have a question for you.
Sure.
One thing I appreciate about you is you are a lifelong student and constantly learning to make yourself better. and also to help your patients and those that you're leading. My question is about technology. Technology is changing everything, and the world of healthcare has seen some of the biggest changes, I think, in recent years. In particular, how has physical therapy benefited from the many technology advantages over the past couple of years, either in education or technology in the home?
Oh, let me tell you, you're talking to somebody, and I'm going to give up my age. I graduated high school in 1984. I'm 55. And when I went to college, all you knew about computers was Fortran and COBOL. Those were the two languages, and you didn't even mess with that unless you were thinking of going into computers. I have been very educated, thank God, by the people that I work with now and in all the facilities I've been in every latest technology change. And every year it seems like technology triples in the amount of space that you can fit on a tiny little chip. Without the technology that I use now, it would have taken phone calls to insurance companies to ask for permission to see these patients. We would be handwriting all of our notes. It would be difficult to communicate with a team. Even the cell phone that I'm talking on, I can merge calls and we can have these calls that we're on right now. Without this technology, I think it would really put back treatment to our patients. I cannot even imagine going back, even to find a patient's home. I used to pull out a map. I used to figure out where I was going, and now we have this wonderful thing called Maps on Google, and all I have to do is push my technology or on my tablet. It'll show where all my patients are. I can map out my day. I have quick access to every other discipline's notes. I can know what the occupational therapist did yesterday. I can look at their plan for the future. I can see how many visits I have planned. And it also helps me with patient education. I can pull out my tablet, go on the internet or my phone, and show a patient the kind of walker I'm thinking about ordering for them, or the kind of ramp that I'm considering suggesting for them. So technology has made me the best clinician that I can be. And I'm glad that I've gotten to see this progression in technology, because I think I appreciate it more than a new grad does. They have no idea the way that we used to work and how much better technology has improved our disciplines. I hope that answered your question.
Yes, it absolutely did. Thank you. That's something that has always piqued my interest with your industry. Specifically because you have so many years of experience and you've really seen an evolution from where you started to where you are now, and it's only continuing to improve.
Yeah, and you know, things do go backwards sometimes. I was shocked when I walked into Best Buy and they're actually selling vinyl records again. Apparently that is a thing.
Yes.
I did not know that.
It is a thing again.
What the heck is going on here? I got rid of all my records. Little did I know.
Well,
I don't think we're going to go back to paper documentation. I pray we don't.
Oh, I know. That's something
so
I would
much
like
faster.
to avoid. Absolutely. If anyone has any more questions after today's seminar, you can always contact Angela directly or reach out to us at the Visiting Nurse Association of Ohio. Angela, thank you so much for your time today. You just have a world of knowledge inside that head of yours. And every time I get to hear you speak, I learn more and more. We're so grateful for you and your education and the knowledge you share. And thank you for joining us today to share just a small piece of that on today's seminar.
You're welcome.
If we have no further questions, we will see everyone next time. Angela, thanks again, and we'll talk again soon. Have a great day, everyone.
Bye.